Hello, Deb Constien again. And I'm giving you my second part, my second debrief. This one was on difficult to treat RA, and it dealt with two case studies. And that was really fascinating to hear about real life people that are affected by all these issues that we have. So, the first breakdown of the first person was they concentrated on difficult to treat RA versus poly-refractory. And I tried to look up because they called it just poly-refractory, but everything I found related to poly-refractory RA. And that is also something that's going to go into the glossary so people can look to the glossary for all the new terms that are floating around or new to us too. They talk about 5 to 20% of RA patients are difficult to treat. And a few, and they say approximately 3% are poly-refractory, so they have different components coming in as well. Since I've had my RA disease 42 years, and I have been on every medication, so all the different types of medications, and have failed them at one point or another, and have gone through several retrials of biologics because I'm kind of out of options. So I am definitely difficult to treat, and see a lot of things coming up that will definitely be difficult decisions on what the next steps are. So let's see, less than 60% of difficult to treat have objective inflammation on imaging, so you can actually see it on the imaging, as well as ultrasound. You can actually see inflammation under the skin, and it's kind of fascinating. It's like, again, different with ultrasound, very different shades of gray, but it's really the people that are trained to read those images are very talented people. So the one person that they actually addressed was, they were trying to decide, was this person a poly-refractory RA and what to do about her, because lots and lots, so her CRP levels were off the charts and inconsistent, so all over the place, but never normal. And imaging showed lots and lots of destruction and inflammation and lots of body parts that were related to this. So they landed on that, and they said the question they posed was, why is the patient so difficult to treat, and what can we do to help poly-refractory RA patients? And they were using the EULAR guidelines and ticking off boxes of how many criteria she met, and you only needed to meet 2 or 3 of the criteria, and she met 8. So definitely issues that were in her way. So what they chose to do, and this patient was a female and 25 years old and had failed all the different levels of medication. So they chose for her to have the CAR T-cell therapy, which Layla reported on yesterday. And sadly, she got 2 of the worst complications with CAR T-cell, and she had, they call it CRS, which is cytokine release syndrome. So your body kind of cyclically keeps going out of control, and everything's inflamed, everything is lots and lots of pain. And she was hospitalized at this point, and she also had a cell-associated neurotoxicity, and it also showed up as another infection. So they were able to treat her in the hospital and got her back stabilized, but I believe they said it took at least 2 months of hospitalization after the CAR T-cell therapy. And she was 1 year out when they checked back in with her, and her DOS score, so the DOS and the CRP, her CRP went back to normal level. in her DAS score, so her daily activity score, no joints were inflamed. She was on no biologics, no DMARDs, and no steroids, and had, like I said, the normal level of a CRP level. So definitely, again, so much is happening in the CAR T world, and that is fascinating. And I've been following all the different steps. So it does give folks like us hope that have been on everything. So that was a really interesting piece. I'm skipping ahead a bit because they did talk about different treatment targets for difficult to treat arthritis, and they call them neuromodulation. So the type of treatments, so they would implant a device in your vagus nerve stimulation. So what they showed, and I will share some of these slides as well to be shared at the same time of the debrief, so you can kind of see some of the slides that I was looking at. It's a really tiny piece. It looks like about your fingertip, and it's really thin, so probably the thinness of a pencil tip, and maybe a quarter of an inch long. And it's implanted onto your vagus nerve, so surgery, so invasive. They use a magnet, so the person and I believe it was just 1 minute of stimulation a day, because more didn't help. So like just the 1 minute, that caused really good outcomes for a lot of people. But again, it's invasive. The other, let's see, there was a vagus nerve stimulation that would trigger your spleen to, the splenic nerve, and the stimulation of the splenic nerve. So on your spleen, there's a splenic nerve. They would activate that as well, and people would have really good turnout as far as using the splenic nerve to communicate with the spleen to release the sensors throughout your body to decrease the pain and things like that. So really interesting things that have been done. They also have a neurostimulation, so it's a device that is, so this is non-invasive, that and I've seen some of the trials. I actually have had some friends that have used this device. You put it up to your neck, and I believe you use this stimulation for cervical stimulation, so it's stimulating into this part of your neck, and it also is stimulating your vagus nerve, but from the outside, not the inside. So that has been a neurostimulation that has been helping with pain and disease activity. There's also, I'm going to say this wrong, AURICULAR. So it's ear, so a device goes into your ear and connects, and they use stimulation from your ear as well. So there's been a lot of different studies in this area to see how people are responding. So the vagus nerve stimulation, like I was saying, the device is implanted on your vagus nerve, and they attach a magnet that lands into your chest area, like right here. You hold a device up to the magnet, and that triggers the vagus nerve stimulation for the 1 minute that I was describing, and just what the setup looked like and how it helped. So long-term follow-up, they were finding that after 24 months of doing it consistently, that the CRP levels were coming back down to close to within normal limits, and the DAS, the daily activity score, when you're filling out the surveys of how many active joints you have, were definitely like plateauing probably after the 12th month to the 24th month in this study. Everything was pretty stable. So interesting as far as just the different ways of they call it like resetting your RA and through these different devices. So interesting things on the horizon for patients like us, and it was a fascinating session, as were all of them. So I'm wrapping up with there, and if you guys have questions after you see my debrief, just call me out in our elevated experience chat, and I'm happy to answer the best I can. So take care. We'll see you. Tune in later as we report back on what we learned today.